Kia ora everyone, welcome to this Goodfellow Unit Webinar on contraception with Dr. Orna McGinn. Orna is a general practitioner and the current Clinical Director of Primary Care Women's Health at Auckland District Health Board. She teaches in Women's Health at Auckland University and she also works in a contraception clinic in Māori, South Auckland. And the webinar tonight is kindly supported by Pharmac. Welcome, Orna.
Thank you, Helen. Thank you.
I'll let you go ahead with the talk this evening.
Okay. First of all, thanks very much to the Goodfellow Unit for asking me to come and talk. And so this evening, I'm going to talk about a few different things. I'm going to talk about what the sort of current state of play is in New Zealand as regards contraception and its access. We're going to go through a few cases, which I hope will highlight some common things you might come up against in your everyday practice. And we're also going to talk a little bit about education and training and changes that might be coming up over the next year or two. And I thought I would just start by saying that it's 51 years since the UN declared that contraception was a universal human right, which cannot be restricted on the basis of race, sex, language, religion, political affiliation, national origin, age, economic status, place of residence, disability status, marital status, sexual orientation, or gender identity. And that really is what I firmly believe as well. So if we have a little look at what's been happening in New Zealand. So New Zealand's got quite a few specific issues, which, again, a lot of you watching will have come up against. And one of the main things is that the access is not the same all around the country. It's patchy. So even within a city, it can be different, and even within practices in the city, because each PHO sets its own access criteria. So you might find that at practice A in Auckland, you can have your Jadel fitted for free, but then if you move house, the PHO who your new practice belongs to don't have the same access criteria, and you may have a large charge to remove it. So those things can create real barriers for patients. Family planning do an absolutely excellent job, but unfortunately they don't cover the whole of the country, and they're very overstretched, and sometimes patients can have a long wait to be seen. There is an issue with some methods of contraception not being funded. Primary care isn't always funded for insertion or removal of LARCs. That's long-acting reversible contraception, which we'll be talking about quite a lot. And again, some forward-thinking DHBs have brought in some really good ideas. I'm thinking of Counties Manukau, down where I work in South Auckland now, where all postnatal contraception is free, and some GPs who've had particular training can offer that for their patients and other people's patients for free. But again, these are just sort of patchy access, which is different everywhere. Because of all these things, there are very high rates of unplanned pregnancy with all the associated risks, both to the mother and the baby. So we know that unplanned pregnancy is associated with poor maternal and fetal mental and physical health, with childhood poverty, and there are also very high rates of teenage pregnancy in New Zealand, which we'll come along to in a minute. And of course, I've already mentioned about training. At the moment, because there's no specific training available in New Zealand, that's led to a real lack of providers. And we do know that the evidence shows that providers are only likely to offer things that they are able to do. So in other words, if you are not able to fit a Jadel or an IUD, you're actually less likely to discuss it. So it becomes a sort of self-fulfilling prophecy, unfortunately. And at the moment, we don't have a national strategy to deal with this, and also nobody owns it. I mean, in the UK, it's quite clear that there's the Faculty of Reproductive and Sexual Health who issue all the up-to-date guidelines. They've got a clinical effectiveness unit who issue up-to-the-minute guidelines and updates, and they are an offshoot of the Royal College of Obs and Gynae, but they are made up of nurses, general practitioners, public health doctors, and obstetricians and gynecologists. It's a sort of multifaceted approach. And unfortunately, we haven't got that as yet here. So I think these are all the things which are really what the background are. Okay, so this slide is from the UNICEF report, which comes out every 5 years, which is Children and the Sustainable Development Goals in Rich Countries. And this UNICEF report looks at aspects of children's health and well-being, such as childhood obesity, child poverty, educational attainment, and adolescent suicide, which was unfortunately, New Zealand had a very high rate in the last UNICEF report. So the reason I put this up is you can see that New Zealand, which might be a surprise to quite a lot of people, is quite far towards the right side of that graph. So we have one of the highest rates of teenage pregnancy in the OECD. And again, this is really important because it's a marker for deprivation and child poverty. And we do know that children of teenage parents are far more likely to become teenage parents themselves, and then that cycle of poverty continues. The other interesting thing to note is that since the previous report was produced, we've actually overtaken the US. So we've swapped places with the US, which is a bit unfortunate because our rates haven't really dropped. Whereas if you can see that over that 10-year period, the line is 2005, the circle's 2010, the blue bar is the most recent stats. You can see that the US had a large drop in that time, but New Zealand unfortunately didn't. And the line, which is only a line because I'm not very techie, because it was actually meant to be an arrow, is just showing the stats from the UK. So the UK has historically had a very high rate of teenage pregnancy. It had the highest rate in Europe for a very long time. But from 1999, for 10 years, and that's the period during which I was training to be a GP, they introduced a multifaceted 10-year reducing teenage pregnancy strategy, which was a sort of whole of system top-down approach, which went across several different government departments because they all agreed that no one department had the answer. And during that time that reducing teenage pregnancy strategy was in place, they managed to halve the rates of teenage pregnancy, which was a huge achievement. And actually the World Health Organization have recognized that, and they invited Alison Hadley, who led the program, who originally trained as a nurse. They've invited her to share the lessons, and Thailand and Mexico so far have been looking at that program and seeing what they can take on board. And you know, it's maybe something that New Zealand could look at, but because we know although the rates are dropping here, they're actually dropping everywhere, and there is evidence that the probably one of the biggest factors in the drop in teenage pregnancy is the increased access to online porn, and I don't think anyone wants to own that, to be honest. Okay, so this was a really important report that came out in 2013. This was a health committee inquiry into improving child health outcomes and preventing child abuse, with a focus on preconception, so before the children were actually born until 3 years of age, because we know that those few years translate into either huge gains or huge disadvantage throughout life. And one of the strongest recommendations from this report was the recommendation that the government at the time develop a coordinated cross-sectoral action plan for sexual and reproductive health, which was to cover the whole country and include world-leading termination and sexual health services, to be developed within 12 months. Now, unfortunately, that hasn't happened as yet. There is a plan in process, but probably isn't going to be as comprehensive as that. And the other recommendation actually that came out of that inquiry was that all contraception should be fully funded, including the Mirena IUS. So as I say, the previous government didn't get a chance, I think, to do much about this, and then now we have a new government who have been looking at it, but we'll see how that goes. So this is something I'm really interested in, is what the barriers to access are for the patients and for the clinicians who want to provide the service. So very generously, the Northland branch of the Royal College of GPs gave me an educational grant to do some research into this. So I spent a few months at the end of last year interviewing about 25 GPs, all the way from Kaitaia down to Invercargill, just to find out what they felt the barriers to access were for themselves and their patients. And universally, the answers were the same. It was the cost to the patients, which they felt in some cases very distressed about. And some GPs I spoke to were providing these services below cost and losing money on providing LARCs, doing JADLs, because they felt so strongly they didn't want to turn the patient away if they had nowhere else to go. And I'm thinking particularly of Hawke's Bay here, which actually doesn't have any family planning provision. And then the other issues that came up time and again was that where there was funding, it was ring-fenced very tightly for specific groups, and those groups perhaps made up only a very small percentage of the GP's list, and so they were having to turn away most of the patients who requested contraception. And then the third issue is training. So I spoke to doctors who'd been on the waiting list for training for, in one case, 4 years actually. There is some access to training via family planning, but family planning aren't funded to provide training, so they have to levy a charge, and it's quite a large charge. It's about $1,200 to sit in for a day, and they don't have specific training, so you may get to do watch and do a few IEDs, but family planning themselves agree that for them wouldn't be enough to equip a practitioner with a solid foundation. That's not how they train their own clinicians. So, it's a big issue because, as I said before, if you can't offer the services yourself, you are less likely to even discuss them. Okay, so this is an interesting paper that came out last year in the Australian and New Zealand Journal of Obs and Gynae, and this was using the Growing Up in New Zealand data, and it showed that actually overall 53% of pregnancies are unplanned, and that's quite surprising. You can see, looking at the left, you'd expect youngsters to have an almost 100% rate of unplanned pregnancy, but you probably wouldn't expect people in their mid-20s and 30s to have almost a third of their pregnancies unplanned. And that again shows that there is a real need for education around contraception and better provision for people at all ages, actually. I'm going to talk a little bit about termination of pregnancy in New Zealand. So this is the New Zealand-wide stats for termination of pregnancy in 2017, and obviously the bulk of those are in Auckland. So that's about 10,000 terminations that took place that year, and we've all seen and counselled women presenting for termination, and it can be very distressing. And you think of 10,000 women in 1 year, and that's a lot of people having to deal with that, and potentially some of these are preventable. And then just sort of looking a little bit further into those figures, I've only got the Auckland stats. Quintile of deprivation, if you're not familiar with them, is a measure of deprivation in an area. It's a geographical area. So quintile 1 will be the least deprived, quintile 5 will be the most deprived, and so you'd expect 20% of any population to be quintile 5 because they're split into the poorest 20% will be quintile 5. So you can see that disproportionately the poorest people are having more terminations. Is this a reflection of access to contraception, or is it more complicated? I suspect it's more complex than that. And then the other thing, again, as is borne out by those other figures I just showed you, with unplanned pregnancy being common across the board, terminations are common, and the highest rates are in people from their mid-20s to their mid-30s. And it sort of doesn't tally so well with, family planning who have their access criteria set, by the ministry, is free for under 22s. But you can see, looking here, that they're not the only people having unplanned pregnancies and requiring access to termination. And then just to show that, again, across the board, termination can affect any woman in New Zealand. Okay, so a little bit about the economics of contraception, and it's really one of the things I like about contraception is because it sort of does what it says on the tin. When you're working as a GP or as a practice nurse or even as a pharmacist, actually, because I know there's some pharmacists working, that a lot of the things that you're doing for the patient are probably not always evidence-based, and sometimes not much better than placebo. And we know that, you know, a lot of what we're giving is homespun wisdom, and there's nothing wrong with that, because that's got, you know,
it works.
Yeah, because it really works. But I would love to have a treatment for depression, for instance, that had a 0.1% failure rate. Or I would love to say to my patients with a high risk of cardiovascular disease, I can give you 99.9% chance of preventing that with this medication. But we can't, but we can do that with contraception. So we've got effective contraception. It's just getting it out there and making the access easier. So, you know, the NHS in the UK has estimated that, I didn't have a pound sign, so that's why it says dollars, but it's £11 for every pound in the UK spent on contraception is saved. And that's in antenatal costs, postnatal, intrapartum care, and termination of pregnancy, even leaving aside the ongoing sort of societal costs, maybe of unplanned pregnancy in very young women. And in the UK, NICE, the National Institute for Clinical Effectiveness, strongly recommends LARCs as first-line contraception because they're cost-effective after just 1 year of use, including the Mirena, and including costs associated with training people to be able to offer these. So, you know, the economic case is definitely there. And then there was a really interesting study that started in the US in 2006, which was called the Contraceptive Choice Study. And this was really about trying to show that if women didn't have access restricted by barriers such as cost, what would they actually choose to use for contraception? So this was based in St. Louis, this study, or St. Louis, I'm not sure how you want to pronounce it, maybe someone will tell me. But it looked at over 9,000 women aged between 14 and 45. And they were counselled from a standard pro forma with all the advantages and disadvantages of each method of contraception. They had access to whatever form of contraception they chose at no cost. And almost 75% of those women chose a long-acting contraception. And that's really quite startling. At the beginning of the study, they estimated around 5% of women were using LARCs. So it just, you know, really shows if cost isn't a barrier, this is what most women would choose. And then, of course, what's important is, do they carry on using those methods? And, you know, whatever the woman's age, the continuation rates were well over 80% or 86% in women over 25. And these findings, if they were replicated in the general population, would reduce unintended pregnancy by 64%, unintended births by 63%, and abortions by 67%. So, again, very interesting. This is sort of the other bit of economics. So it's difficult to explain this, but if anyone can, please do. So in New Zealand, antenatal care is free, entirely free. GPs are paid to see a woman who presents in the first trimester. So when a lady comes in and says she's pregnant, and you do all the initial tests, you do the blood tests, you order the scan, we are paid a fee for that. Whether that woman is then going to be referred on to a midwife or whether she requests termination. So we have a funding agreement, so we get paid more actually for referring a woman for termination. If a woman does go for termination, that is free, and now the gold standard is for post-termination, the woman to be offered long-acting reversible contraception. And Helen Roberts here in Auckland has done amazing work around that and showing that it's acceptable and it works and it reduces repeat termination. And LARCs are increasingly being offered free post-delivery as well. And again, I've already mentioned that happens in Counties Manukau down in South Auckland, and around the country I'm hearing of schemes like that as well. But patients have to pay for contraception. And, you know, primary care is all about prevention and planned proactive care, and I do feel that contraception is probably one of the greatest examples of planned proactive care that we can offer. Okay, so talking of primary care, this is where I work in East Auckland, and that's one of my colleagues, Eileen. And this was at the opening of our new building towards the end of last year, and we had a special guest, as you can see on the right there. So I'll just talk a little bit about a few cases, which just will highlight a few pointers. I can see there's a few questions.
Yeah, there's a question that's come in about migraines with Aura. So
yeah, so
I think
we are
you're
going
about
to be talking about that.
Yeah.
Good. So, but please keep asking questions if I don't cover it. So here's a 37-year-old lady. She's had 3 babies. Her BMI is in the normal range, and she is on Levelin, which is a funded combined oral contraceptive. And she's noticed for quite a few months that she's having bad one-sided headaches. But what she tends to do is just take some Nurofen and lie down and go to sleep, and they go away. So she came in, I checked her blood pressure, and I asked her to describe the headaches. And anyone listening at home who suffers from a focal migraine, I want you now to think to yourself how you would describe that migraine to somebody. Okay, because I get the students to do this, and it's one of the most amazing clinical signs that I've been able to demonstrate. So watch the patient's hands, because I have focal migraines, and if I'm describing them to somebody, I say, oh, I get this flashing light. Is that same?
Yes. It's exactly it.
Yeah, that's right. But you move your hands.
Yeah.
It's a clinical sign. It's been reported as a clinical sign. So if that's what your patient does, they have a focal migraine. And these scintillations that you can see are really quite typical. Focal migraines are a contraindication to the combined pill because the risk of stroke really is quite marked. And I've written down at the bottom there that it's UK MEC4, and MEC is the medical eligibility criteria. And you can just Google those. They're free to access on the Faculty of Reproductive and Sexual Health website. And I've got this at the end of the talk as well. And the medical eligibility criteria for all contraception is divided into 4 categories, and 1 means there's no restriction on use, 2 you can usually use, 3 you usually don't use, and 4 avoid like the plague. So that's focal migraine. So I'm only briefly going to talk about the pill because
the question that came in was just about migraine with Aura and the combined contraceptive pill. Is this still a concern as per the UK MEC? One of our GPs indicated a new finding that this does no longer increase the risk of stroke.
No, it's absolutely a no-no.
Yep.
In fact, interestingly, I discovered recently that if you develop new migraines, not even focal migraines, if you develop new migraines while on the pill, that's actually MEC3. So that's also, you probably shouldn't be on the combined pill, even if you develop non-focal migraines. But yeah, focal migraines, complete no-no.
And one more that's come through, if it's been more than 5 years since a woman has experienced a focal migraine, is it then okay for them to take the contraceptive pill?
No, it's still
ongoing.
Yeah, it's still ongoing.
Yeah.
I must admit, I did see that advice somewhere a long time ago, but I looked it up again recently, and no, it's a no-no. There's quite a few questions. I'll just quickly carry on.
Carry on. I'll go through.
So the reason I put up that slightly retro picture is because I think the pill is yesterday's medicine, but that's just me, and a lot of people are very happy on it. But the only reason I say that somewhat facetiously is because it does have a higher failure rate than some people appreciate. The failure rate is in the realms of 9 to 10%, which really is pretty high. And also, I think a lot of the time it's offered just because people might have been on the pill for a long, long time, and they come in for another pill prescription, and actually you don't think to say, have you thought about anything else? And often if you do, people say, oh, I hadn't thought. For instance, if someone comes in and they're 34 and they finish their family, and you say to them, look, you could potentially have 20 years left of pill taking, that's something like 6,000 pills. Would you consider, taking something that might last you 5 or 10 years? And they might often change their mind. The pill has a lot of advantages. Number one, it's under the woman's control. She can start it and stop it when she wants. And obviously, it's fantastic if you are looking for something short term, you're spacing out your family. But it does have a lot of disadvantages as well. There's a lot of people who can't have it. I won't go through all the criteria, but there's a lot of people who can't have it. We've just talked about migraines. And the other thing, actually, that probably people don't realise, it's not really recommended in people with a BMI over 35. We've got a lot of people with BMI over 35. But in those women, the risk of DVT, again, really is quite appreciable. And it's a good idea maybe just to think about, would they be interested in something else? down the bottom, that actually stands for why the pill-free interval. So because I was going to talk a little bit about tailored regimes. So again, this is probably a lot of people have been doing this for a while anyway, but it's now sort of official advice. The problem with the pill-free interval, it is a little bit weird, giving a patient a medication you're telling her not to take 25% of the time. And it's very easy for people to get confused and start their next packet on the wrong day. And probably the worst thing you can do, the worst pill you can miss, is the first one in the next packet. Because during the pill-free week, your ovaries are going to withdraw from the effects of the hormones. And as I've shown in the little graph down the bottom, the level of FSH, follicle stimulating hormone, starts to rise. If you track follicular activity in the ovary during the pill-free week, you can see that there are follicles developing which potentially could get large enough to release an egg. So that grey line is looking at how high the FSH rises if you have a 7-day hormone-free interval. But the blue one is a shortened hormone-free interval or pill-free interval. So you can see that the FSH doesn't rise as much, so follicles don't develop. You have less of a chance of an escape ovulation. So some regimes you can try with your patients. Instead of, we've been tricycling for a long time with, maybe 3 packets on and a week off, but you could advise them to do 21 days on and 4 days off, so a shorter pill-free interval. The other thing you can do is 3 packets, so 63 tablets and 4 days off. Or they can do 365 days a year pill taking. There is more chance of unpredictable bleeding with that, but what you can advise is after they've taken 3 weeks worth of pills, they can then, whenever they get bleeding that's unacceptable, have a 4-day break and then start again. So it's really tailored to the individual. Now, the only thing I'll say with all of this is this has taken me a few minutes to explain to you. We've only got short consultation times. And so a proper consultation for contraception really does take some time. And if you are trying to do that with a young person and give them a lot of information, they can often get very confused. So written information is absolutely vital, and maybe even a follow-up phone call to make sure they understand. Because I think some of the time I've seen my patients are nodding, and then if you say, "Do you understand that?" they'll admit no. And so I do try and explain it again and always send them away with something written. Anyway, so this is something that happens a lot. So Amelia had already worked out that the pill was probably contributing to her headaches. So before she came in, she had stopped it, which I congratulated her on. That's very good. I think that was the right thing to do. But unfortunately, she then had sort of forgotten she didn't really have any contraception on board. And on questioning, she had actually had sex the night before. What do you do in that situation?
Just before we go on it, we've just got a few questions that have come in around the headache things. I think we should maybe address that now, just before we move on any further. Someone's mentioned that the data that we have around the migraines and the headaches is for 50 microgram pills, not for 20 and 30 microgram pills. Is that right?
Oh, sorry, say that again.
Someone's mentioned that the data that we have around migraines and headaches with the pill is around the 50 microgram dose pills rather than the 20 and 30 microgram dose pills. Is that right?
Well, we don't often use the 50 microgram pills. So the advice is whatever the pill strength is, focal migraines are MEC4. And I wouldn't have thought there was too much of a problem with that. I can see that one of my very special family planning friends is listening in. And Helen, if you know differently, please correct.
It was Helen mentioning that.
Yeah.
I've also had, what about non-migraine headaches with the combined contraceptive pill?
Well, I did just mention that briefly, that if you develop new migraines while on the pill, that then is MEC3. So the advice would be, if there was another method, that would be preferable.
Yes, and if it's a non-migraine headache, then it's just possibly about changing pills or adapting a regime. And someone said that their neurologists have been suggesting that people can take the pill despite having migraines. So I guess that may be specific to particular cases and nothing that you've heard done before.
No,
No.
not really. But that's an interesting thing to look into, actually.
Yeah. And that's, someone's also mentioned that it was MEC3, I think, and if it has been a migraine that has been over 5 years ago since they had their last one. The last one was, what age would you recommend stopping the pill? And is there a certain amount of years you'd recommend them only taking it for?
Well, no, you can take the pill all the way up to menopause, actually, if a woman doesn't have any other restrictions. But of course, as women get into their 40s, late 40s, other things may come on board, like hypertension, which make it a less suitable method. But with no restrictions around that, then they can use it all the way up to menopause. And the recommendation is really to use contraception up until arbitrarily the age of 55 and then stop it.
Yeah, and Helen's just written back in saying all doses of the pill, so the 50, 20 and 30 microgram MEC4 for migraine.
Thank you, Helen. Helen's being my accessory brain today.
Let's carry on.
So that's Amelia. Okay, so I just wanted to talk a little bit about emergency contraception. All right, so I was just going to go back to basics here because I really find it helpful just to look at pictures. I'm very picture-y sort of a person. So you can see that ovulation has occurred, and then the egg gets fertilized in the tube, moves down the tube, and then the earliest date of implant would never be before day 6 to 7. So this is the basis of using the copper IUD as emergency contraception, because if you put it in up to 5 days after ovulation or up to 5 days after unprotected sex, you know that you will not be disrupting an implanted fertilized egg and thereby inadvertently procuring an abortion. So the copper IUD works because it prevents implantation at this stage, and then when it's not used as emergency contraception, it works by preventing fertilization because it's toxic to sperm. So obviously, then I'm also going to talk about the emergency contraceptive pill, and this is a slide I put up for my medical students, and they have to tell me what 1, 2, 3, and 4 are. But I'll tell you that 3 is LH, so luteinizing hormone. So LH, you get a big surge just before ovulation, and that triggers ovulation. So the point of when to give the emergency contraceptive pill is that by the time that LH surge has started, it's like an unstoppable beast. You can't stop it. Ovulation will occur. And so if you give emergency contraception at or around the time of ovulation, it's really too late because it works by delaying ovulation. So it's really important to know when the patient's last menstrual period was when you are offering emergency contraception, because if the patient is at or around the time of ovulation, as I say, the ECP is not going to prevent ovulation. And actually, it doesn't prevent it, it just puts it off by up to 5 days, by which time there won't be any live sperm around. But the patient can still ovulate later in the cycle, so it's really important to send them away with a method of contraception, or let them know that they are still in danger of getting pregnant in the rest of that cycle. You can use it up to 72 hours. ECP does have an appreciably higher failure rate than the copper IUD. And again, I've seen conflicting things around this, and perhaps Helen might be able to help me here, but 5% I've seen. I've also seen that it prevents 58% of pregnancies at 72 hours, so the earlier you give it, the better. That was from MedSafe. And then the other issue is, do we now need to consider giving 2 tablets if the woman is over 70 kilos? Because, that would, again, affect a lot of our patients. I know that family planning do this as standard, and to me, if family planning do it, we should all be doing it. So I think probably that should be the new advice. And interestingly, when I came in here this evening, I did see that on the front of the Goodfellow site, that was a Goodfellow gem. So I just thought, at least I'm agreeing with that. And then, of course, the advantage is that the IUD is not affected by weight. Of course, in the real world, how do you offer an emergency IUD, in a busy clinic with maybe no one on hand who can fit the IUD? You might have a colleague who's only working part-time, is not in for 2 days. In reality, it's really difficult, and this is another reason why we need to look at the whole issue around access, and there maybe being more community clinics. Any more questions around that before I go on to the
Yeah,
next
there's a few
case,
things
Helen?
in emergency contraception. One of them, which is you've established there, I think if we go back,
Yeah.
that at or around ovulation and after ovulation, the ECP is not going to work. It's no better than placebo.
Yeah.
Can we use the ECP more than once in the same cycle?
Yes, you can, is the answer.
Okay, fantastic. And does it have any efficacy in day 4 to 5 after unprotected sexual intercourse? Well, that's obviously related to the ovulation time.
Yeah, I mean, at that stage, you can use it, but again, it wouldn't really be doing much more than placebo. And if someone presented at that stage and really didn't want a pregnancy, you would be advised to try and get them access to an emergency IUD. And again, family planning, if you phone them and you have a situation like that, they will usually do their very best to fit the patient in.
I think there's been, Helen's written in saying there's little data on weight, but yes, it is recommended to take 2 tablets if greater than 70 kilograms. And someone's asked if that's more or less accurate than a BMI of greater than 26 for giving 2. And I guess they're both recommended, and certainly that came through in the gem that Bruce Harrell sent out.
Yeah, well. Actually, I've got a question for any pharmacists listening, because if a patient buys the ECP over the counter and they are over 70 kilos, would they have to pay for a double dose? Because it's a relatively expensive option to buy over the counter.
Yes, and it makes it a bit more difficult in a setting in a kind of pharmacy, I imagine, where you're having to ask a BMI or weigh someone.
Absolutely, yeah, absolutely. So that's important. So I might just go on to the next case quickly. So Hannah, so this is another patient I saw recently, but I've changed some details. So Hannah is one of my patients who, she has quite a high BMI. BMI is 51. She's been in a long-term relationship with her partner for 3 years. She was worried about the extent of her weight gain, and she was concerned that it might be caused by the pill. So she stopped the pill and had only been using condoms since. When she actually came in to see me because she hadn't had a period for a while, but she wasn't so worried about that because her periods were not always regular, but she had pain in her pelvis. When we talked about after she stopped the pill and she had been using condoms, I asked how she'd got on with them, and she said, well, actually, I had a miscarriage about 6 months after coming off the pill, and she said I dodged a bullet. So I took that as an opportunity to ask her, would she be keen on using something a little bit more reliable? But first of all, we had to make sure that she wasn't already pregnant, because she had this story of not having had a period for about 6 weeks. She was a little bit vague, and she had low abdominal pelvic pain. Anyway, to the relief of both of us, it turned out to be a urinary tract infection and not an ectopic pregnancy. And we talked about different options, and she was really keen on Tidal, and understandably said, well, I'm here now, can I have it today? So, can she have it today? That is the question. So what questions do we need to ask? What are the issues here? Well, we already know she's at risk of unplanned pregnancy. She's had an unplanned pregnancy already, and the failure rate of condoms is really about 18%, which again I think surprises quite a lot of people. Even people who are really careful. I've seen quite a number of pregnancies, people using condoms. Hannah's raised BMI means that the pill really wouldn't be very suitable for her because of the risks of things like DVT. We need to know, does she have any other risks? Does she smoke? Does she need an STI screen? She's under 25, so that would put her at increased risk of an STI. But on the other hand, she's been in a long-term relationship for 3 years, so probably not. Has she had any unprotected sex? Has she not used condoms? No, she's absolutely adamant that she's always used them, so we don't need to consider emergency contraception today. So the question is, can she have the Tidal today? Answers on a postcard. So basically, what we're talking about here is quick starting. So quick starting is it really, really changed my practice actually when I started doing this, because the advice we were always given was, start the pill during your next period, or come in and have your IUD fitted during a period, or well, what about women who have irregular periods? I mean, how long are you going to wait? And the other issue is people may lose the enthusiasm. I mean, if I couldn't do anything for Hannah today, she's really busy, she works full time. When is she going to be able to come back? And we already know that she's at risk of pregnancy. So I'm very keen to do it for her today. She's more likely to remember any instructions I give her. She's very enthusiastic. If you send people away, they will lose the enthusiasm often. There's obviously less chance for pregnancy if you fit the device that day. And WHO now recommends this strongly to quick start contraception, which is starting at any other time rather than during a period, if you possibly can. You can do this as long as you can reasonably exclude pregnancy. So, reasonably excluding pregnancy is these very clear criteria. So if a woman is less than 7 days since her last period started, she has a very reasonable chance of not being pregnant. If she's had no sex since the start of her last period, if she's within 4 weeks of giving birth, if she's fully breastfeeding, not had a period, and within 6 months of delivery, because that's the lactational amenorrhea method of contraception, and that is 98% effective. And if the patient is correctly and consistently using contraception, including condoms. So in other words, yes, Hannah can have her Jadel today, but to be extra careful, because she hasn't had a period for 6 weeks and I'm a little bit suspicious of condoms, I would advise her to have a pregnancy test in 3 weeks, and then we can be 100% sure that she's not pregnant. I think the worry used to be that if you put in a Jadel or offered oral contraception and you weren't sure the patient wasn't pregnant, could the hormones harm the fetus? And the answer to that is no. So we can be quite sure that the progesterone in the Jadel, even if she did have a very early pregnancy, would not be harmful. But again, even if we want to give Hannah her Jadel today, we are up against the reality of maybe not having the time or the resources. And that's another barrier to quick starting contraception in practice. We know what we want to be able to do, but sometimes we can't always do it. A lot of people also worry about Jadel and the bleeding, and I have heard a fair number of GPs say that they don't recommend it because they think the bleeding rates are too high, which is a shame, because I think it's probably up to the patient to decide how much bleeding is too much bleeding. And some people will put up with bleeding just to know that they are definitely not going to get pregnant. But these are the official figures on bleeding. So 2 in 10 will have no bleeding at all with Jadel. 3 in 10 have infrequent spotting, 1 in 10 have frequent bleeding, and 2 in 10 have prolonged bleeding. So I suppose that's about a third who have some sort of irritating bleeding. It's really important when you're counselling someone about the Jadel to let them know that this is a possibility, and if it happens, not to wait, but to come back to discuss, because there's things we can do. And usually you can do a cycle of the oral contraceptive pill, or you can give mefenamic acid if they can't take the pill. And if you want specific advice about that, have a look at the Goodfellow Jadel module, because it's all in there, and it's probably quicker than answering every single query this evening, I guess, because the module's got every single thing about the Jadel in it. One other thing I probably would say is that if people start bleeding at the beginning and it's persisting, it is likely to stay like that, because I have come across a lot of patients who've been told again and again, keep going, it'll go, but often it doesn't, and then by the time they come, it's very difficult to persuade them that they can be helped with the pill, because they just want it gone. Just want it out by then. Okay, and because I thought this was a good opportunity actually to talk about weight and its effect on contraception and its effect on weight. And there's a really useful full guideline that came out again from the Faculty of Reproductive and Sexual Health not too long ago about weight and contraception. It's probably worth looking that up. We've already mentioned that the pill is probably not recommended with people with a high BMI. The other thing I think is quite important to highlight is that Jeanette, which is very commonly used in New Zealand and often long term, carries a much higher DVT risk than other oral contraceptive pills. When I was in the UK, and I think it's still the case, we were recommended to change people off Jeanette after a year. It was really a short-term issue for women who needed a combined pill plus treatment for acne. but it was a short-term thing before putting them on something else because of the DVT risk. But often you see women here who are on it for many years. So, if you can just remember whenever you see someone on Jeanette that it's not the safest pill to be on. But again, I do understand that some women are very keen on it because it really has made a difference to their skin. Weight, do we need to replace the Jadel more frequently in women over 60 kilos? That's advice that came from MedSafe in 2016, but the jury is really out on that. There's not really very, very good evidence that the Jadel sort of runs out of gas earlier in women who are very heavy. So I don't know if that is blanket recommendations yet. And the other issue with it is if you are having to pay for your contraception, you're having to pay for it every 4 years rather than every 5 years. In the UK, they use a single rod, Nexplanon, and they have evidence going all the way up to 150 kilos, which suggests that it has no effect on weight. So if we were extrapolating from that, which we do with most other things to do with Jadel, then there would be no effect. But as I say, MedSafe did put out this recommendation in 2016, and maybe that's another one that my second in command, Helen, can help me with. The other thing that, it's only anecdotal, but are there increased rates of abnormal bleeding in heavier women? Because they do tend to suffer more with menorrhagia, and I do feel that I'm taking out far more Jadels in heavier women for abnormal bleeding. We've talked about emergency contraception, probably doubling the dose if the woman is over 70 kilos, and both the copper IUD and the Mirena are not affected by weight. And I'm going to talk a little bit more about that and Mirena's role in the prevention of endometrial hyperplasia. Any questions there I need to
We've had a couple of things come through. One of them is from the pharmacist. So thank you everyone who's written and said that the 2 emergency contraceptive pills are fully funded throughout the country because the pills themselves are funded. So thank you for asking the question. Thank you for answering the question.
But if they have to buy it over the counter?
Yes, so they can give it for free over the counter as well.
Oh, that's really interesting.
Yeah. I think most of the Jadel stuff you've answered. There's a couple here. You've talked about the high BMI, so that was one of the questions. And actually, a number of people have written and asked, once you do your 3 months of the combined contraceptive pill with the Jadel, if they're having an issue with bleeding, does that change the bleeding pattern once you stop it, or does it just mask the bleeding and restart again once you stop?
Oh, it's really individual. So that in a nutshell, it's really individual. I mean, what you can do, you just trial it for 3 months and then stop and see what happens. Yes. And I mean, worst case scenario, they may have to be on the pill really maybe constantly on and off to control the bleeding, but then it doesn't matter if they have a problem remembering it or they forget it because they've got their backup of the Jadel, which is there as their fail-safe contraception.
Someone has asked, is there any role for a 4-rod implant for patients with large BMI?
Not that I know of. No, I mean, that sounds like the old, what was it, Norplant with the 7? Oh my goodness, it's hard enough. I tell you, there's enough issues with taking out the 2 implants. Can you imagine if there were 4? So, no.
Okay. And with the weight and contraception, in terms of the progesterone-only pill, does increased weight decrease the effectiveness of the progesterone-only pill?
No, it doesn't actually. No. And I suppose just a quick word on the progesterone-only pill. I said that I wasn't that fond of the combined pill, but I'm actually even less fond of the progesterone-only pill because its main effect is really just making cervical mucus really thick, so acting like a barrier. And that effect is, begins to be lost if you are more than 4 hours late for taking it. So I think it definitely has a role, say, in a woman who's given birth and is breastfeeding, and then it's absolutely excellent to top up the sort of lactational amenorrhea method. But it's not terrifically reliable unless you can afford the unfunded Cerazette, whose main action is actually to prevent ovulation, rather than just use that sort of barrier.
Just 2 quick things. The Jeanette, does it actually have evidence that it changes people's acne, that it helps people's acne? And is there any other?
Yeah, because it has an anti-androgen in it. Is there any other contraceptive pill which does that?
Will do the same, yeah.
Well, there's some question around Yaz and Yasmin, but they are unfunded. Yeah.
And is the DVT risk the highest in the first year? A number of people have written in saying that they understood it was highest in the first year and then it dropped. Is that your understanding?
Yeah, that's absolutely right. So the highest risk is soon after starting the pill.
Okay.
Yeah.
Okay, let's move forward.
All right. So we're just going to talk a little bit about obesity in New Zealand. So this is it's a big issue. New Zealand now has the third highest rate of obesity in the world, behind the US and Mexico. Actually, I think it's the other way around, Mexico and the US. So this is an issue that affects a huge number of women, and it's something we really have to take account of when we are looking at the provision of contraception. And you can see when we look at the breakdown that this affects Pacific and Maori women disproportionately as well, who may already have maybe other health issues as well. And this has an effect on their choice of contraceptions, because fewer of them will be suitable for things like combined oral contraception, but they are not always having access to the more effective long-acting methods. A really, really important issue is, as BMI increases, the risk of endometrial cancer increases, and it doesn't increase in a linear fashion. Above a BMI of about 27, it begins to increase much more steeply, such that a woman with a BMI of 42 has a 9 times increased risk compared with a woman with a BMI of 22. So we know from trials that Mirena, when used for heavy menstrual bleeding, is associated with an up to 75% reduction in endometrial cancer compared with premenopausal controls. And we also know that it's used for treatment of endometrial hyperplasia in women, and we also know that Mirena is used in younger women with endometrial cancer who wish to preserve their fertility. But I think the issue is probably prevention, really, rather than sort of shutting the stable door. So it would be nice if it was available as an option for women who are at increased risk of endometrial hyperplasia, such as women with polycystic ovarian syndrome who may only have intermittent periods during a year, or women with a raised BMI who, this happens very commonly in our population. This study from the Journal of the National Cancer Institute, which came out last year, was really quite startling. It looked at patterns in endometrial cancer incidence from 1978 to 2013. And where the arrow is, you can see New Zealand. New Zealand has one of the world's fastest rising rates of endometrial cancer in young women aged 25 to 49. And this really is, startling is the word. And I think it's probably one of those things that we have some forms of prevention for, which are more accessible than others. I mean, we all know that trying to help our patients lose weight is really difficult. We can't offer everyone bariatric surgery either to reverse the effects of obesity on things like diabetes and endometrial hyperplasia. But, perhaps it would be good if we had other things that we could offer. It's definitely an equity issue because, again, we know that it affects Maori and Pacific women. Okay, we're going to skip through that. I'm just briefly going to talk about postnatal contraception. This is my last case. So Maya, 37, has just had her second baby. She's had a really tricky time. She had an emergency cesarean under general anaesthetic with her first baby, and after that she developed severe postnatal depression and post-traumatic stress disorder, and she was under maternal mental health. She was under maternal mental health still when she fell pregnant again in 2017, and she was looked after by psychiatry throughout the pregnancy, and was on olanzapine and citalopram. She then had another difficult delivery with a 3rd-degree tear and major anxiety, and was admitted to respite care. And she requested a LARC. She came to see me at the postnatal check, and it was a bit of a shame because the practice I work in crosses borders, and most of my patients are counties Manukau, where, as I say, we're lucky enough to be able to offer postnatal contraception for free. But this lady lived just in the ADHB border, so I couldn't offer her a free IED. So what we had to do was find some funding. And actually, when I was interviewing GPs around the country for the study, one of the things that they all told me was that they were scrabbling around looking under the sofa cushions for funding often to get contraception for their patients. And so what we did in the end in our practice, we had a budget for something called planned proactive care, which was mainly used for looking after people who, say, had a new diagnosis of diabetes and required a lot of intensive input. But we successfully discussed with the PHO that in this case, preventing a pregnancy was planned proactive care. So we were able to access that funding. But it's sort of, a shame that you have to advocate so hard for your patients when it's quite clear that they need it. But that just leads me on really to just briefly talking about postnatal contraception. IUDs can be put in before 48 hours. Sometimes they're put in at the time of after delivery of the placenta now at some centres. I know down in the South Island and at Auckland they've started doing it, or after 28 days. But it's important to know that if you are putting in an IUD in a postnatal woman, if she's breastfeeding, the rate of perforation is increased. So, just be mindful. Pill you can take from 6 weeks, Jadel from day one. Jadel does not affect breastfeeding. And if possible, for postnatal contraception, initiation should be available before their discharge from their maternity unit, or referral to a suitable service arranged, because that's a really good time to talk about contraception postnatally. So, in a nutshell, discuss LARC whenever you can. Quick start if you possibly can. Always discuss that IUDs have a lower failure rate if someone presents for emergency contraception. Know what your local referral pathways are, because if you can't offer them in the practice, perhaps you may be able to refer to somebody who does. Always give written information, and there's a few websites down there that I direct the patient to. And I've just made the point down there that, knowledge is power, but sometimes the system makes it a bit difficult for us to do what we'd like to do. Right, should we move on to education briefly?
Yes.
Any questions?
Actually, no.
No?
A couple of questions first. One is, why does the breastfeeding increase the perforation rate so much more?
Ooh, it just does.
Okay.
Thank you, Alan.
I didn't notice Alan.
That's from Alan.
Right, okay.
Helen, that's one for you.
Well, we'll see if Helen can get back to us on that. And the Mirena, can you use it with someone who has had breast cancer and is on tamoxifen in order to offset the risk of endometrial hyperplasia?
Oh, that's when I would phone a friend.
Okay.
Yeah, I would definitely discuss that with
okay.
oncology.
Okay.
Yeah.
There's a few more coming in.
Yes, you can start the pill at 6 weeks, even if breastfeeding.
Yes.
Yeah.
And how about how early can a woman have depot postpartum?
So the answer is perhaps the uterus is smaller and maybe thinner, says my obstetric backup, which is why the perforation rates may be higher.
Right. So that was related to the perforation with IUD insertion after postpartum. And sorry, the question that I was in the middle of asking was how early can a woman have depot postpartum?
Oh, immediately.
Okay.
Yeah.
Okay.
So again, often on the postnatal wards, they will get it before they leave. Some centres are really doing a lot of work around this. Mm-hmm. Yeah. Okay.
Fantastic. I think we should move forward to the training, because this is important.
This is important. Oh, training. Okay. So training, I feel, really should be the same for everybody, whether you are nurse, midwife, doctor, whether you work in the DHB, primary care, family planning, or wherever. I think it's important that if we are going to start training in New Zealand, everyone has to do the same training to the same standard. So in the UK now they do, and in Australia they've got pretty decent training as well. Online learning, because it's flexible. You can do it whenever suits you, and it's just easier. So there is an online learning platform which has been licensed in 30 different countries, which was developed in the UK, which we are looking at here, and maybe that will be introduced. And the 2 modules that I did for the Goodfellow unit were actually based on that UK e-learning, but I just did those because we didn't have a Jadel one, and I just thought we needed it. Structured practical training is important. So structured practical training where you are shown what to do, and then you make sure that you know what you're doing afterwards. And then ongoing, having to do a minimum number of procedures over a cycle, because again, it's important that you do enough to keep your skills up, and that increases safety. And then to do regular CME, because things change, as we've learned this evening. Okay, so I think this is probably the only time I'll ever be quoting Donald Rumsfeld, but I do like this because I think some of the I've had some feedback that creating requirements for training credentialing is a barrier, and maybe less people will train, and so less people will be offering it. Well, it really isn't the case. So when you go out and ask the questions, it's actually the lack of training which is the barrier. And the other thing I think is people who feel that doing the procedures themselves is straightforward. I completely agree. They are very straightforward procedures. But until you've had a serious complication, perforated uterus, or a really deeply inserted jadal, if you don't know that those things can happen, you don't fear them. So I think you have to know what you don't know, because if you don't know what you don't know, you can probably get a false sense of security. And now we will remove Donald Rumsfeld from the screen. So practical training is not the same as see one, do one, teach one. See one, do one, teach one is old styley. Practical training is a structured set of competencies which you reach. And RANZCOG in Australia set up a structured set of competencies in 2012 around IUD insertion, which you can Google and find. So it just shows the sort of dissonance between RANZCOG in Australia and RANZCOG in New Zealand, because although there's a NS in the middle of it, they actually do quite different things. Now, looking at training, some practitioners may only need insertion training. So, for instance, if you are a midwife wanting to train to put in jadals, it's very likely you'll never have to remove one. So you may only need insertion training. Same if you work for an abortion provider, you may well only ever need to insert a jadal. So, the training has to fit the circumstance. And it's important to train in a hub where you're guaranteed to see enough procedures to get confident. And the other thing which is sort of overlooked is actually learning how to counsel these patients, because the procedure isn't the whole story. It's being able to counsel on all methods, and do a really comfortable contraception and sexual health consult, because you don't want to be this person. It's a little bit difficult to say to the patient who has had the extremely rare complication that you learnt your procedure on YouTube, or you once watched somebody do it in a clinic. It doesn't protect the patient, and it doesn't protect the doctor. And there was a spate of deeply sited implants sort of going into the brachial artery and migrating into the pulmonary vasculature, which were reported a few years ago. And again, I think if you don't know these things can happen, that's why you don't worry about them. But they do happen. This was actually the single rod implant, Nexplanon. And I have to say, until I heard about these cases, I didn't know it could happen either. But that's why credentialing, although it may be a can of worms, is probably something we should have an honest discussion about. So what is it? And whose responsibility is it? Should it be the individual colleges, the College of Midwives, RANZCOG, or the GP College? Should it be the DHBs, who at the moment have some money set aside to facilitate better access to LARCs and training? This is all up for discussion at the moment. But credentialing, meaning being trained to a required standard, assures the funder, who's paying for the procedure, and the public, that you have reached a minimum standard of competency and that you're safe. And as I've repeatedly said, this evening, practitioners are much more likely to offer methods that they're familiar and confident and competent with. After those, case reports came out of implants being deeply sited and travelling where they weren't wanted, the Clinical Effectiveness Unit in the UK issued this guideline that healthcare practitioners should hold the letter of confidence in subdermal implants, which is what you do in the UK, or equivalent, having undergone formal training, maintain their competence, and attended regular updates. So they mandate that you should be doing 12 procedures a year to maintain your competence. And the New Zealand prescriber update, not too long after jadal was introduced, said again that jadal must only be administered by healthcare practitioners who've been fully trained in insertion and removal. But then, what does that actually mean? Because there is no, or hasn't been up till now, any structured training. And we do know that there's been a big problem with deeply sited implants. I did a search on a couple of years ago on how many ACC reports there had been on deeply sighted implants having to go to plastic surgery. It's a lot, and that costs that costs money, and it costs the patient a lot of time and distress, and it can be avoided with good training. So anyway, I would never sit here and complain if I didn't have an idea to offer. So this is just a bit of a wish list, really. It would be lovely to see contraception free at the point of access to women who requested it. Wherever they went, it would cost the same, which would be nothing at all. If we had DHB-funded clinics in the community staffed by a mix of healthcare practitioners, you could then offer a really good women's health service, opportunistic cervical screening or sexual health screening, lots of things you could look at doing. People could roster through there, meaning that they would get regularly exposed to women's health and maintain their competence, because I do know that if you set a target for having to do a certain number of procedures in a year, but you're a nurse or a doctor who works part-time, very difficult to maintain that unless you are able to work in a centre where it's happening a lot. But it would be good to be able to create a first-class workforce of women's health experts, which could then lead on to maybe primary care treatment, such as dealing with menorrhagia, which sometimes inappropriately goes to secondary care. Could we be doing medical terminations in the community? We could then have practice nurses with extended scope, or GPs with special interest, perhaps. We could also have meaningful system-level measures, because at the moment we don't have any way of measuring the number of LARCs we insert, and this is actually very unusual. New Zealand doesn't measure it. Pretty much every other country has an idea of what proportion of their population is using what form of contraception, but New Zealand doesn't, so we don't collate the data. So without a baseline, we don't know how to improve on that. So that's not a measure that we can use to see how the system is functioning at the moment. So that's Professor John Gilbo, who he's like the guru of contraception. He wrote Contraception, Your Questions Answered. And the reason I'm sitting here is because I went to see him talk when I was a GP trainee about 20 years ago. And he's just a really inspirational speaker. So when I went back to the UK last year, I went to hear him talk again, and I said, I love your work. And he consented to having a photo. So yeah, there he is. So anyway, if you've got any questions or feedback, I've put my Auckland University email there, and I'd be really, really happy to hear from anybody.
Thank you, Orna. That's a wonderful wish list. You've got it there with the plans for the future. We've got a little bit of time to go through some of the questions that have come in since then. Some of it is around the training, and I think we'll start with that, given that you've just finished on that topic, which is how many procedures of an IUD or Jadel per year is deemed sufficient to maintain competence, or is there a particular number, or is it just deemed that ongoing competency needs to be done through a scheduled training system?
So, I mean, the thought is that really one procedure a month should be the minimum to maintain competence, because you can very easily lose your confidence, and if you are not confident, it transmits to the patient, and everyone has a horrible experience. But sometimes it's hard to get that number, as I say, unless you work in a practice with a lot of young people, say, or if you work in a DHB where they have a scheme like at counties where you can have postnatal women coming in for contraception. Sometimes it can be really, really hard. So then the question that needs to be asked is, how many people need to be trained? Because if you have too many people trained who are doing very few procedures, that probably isn't satisfactory either. So this is something that has to be worked out. In the UK, we had to re-accredit every 3 years, so you had to send in a logbook with the patient's details and the number that you'd done, and it had to be a minimum of 12 to get a sign-off. I don't know how that would work here, but it's probably the gold standard.
And I think Helen Patterson's written in saying, I think it's important people audit their practice, and that's part of their credentialing for this. There is a number of people written in saying they're very keen to go ahead and do this, so which is great news. There's a lot of enthusiasm, and practice nurses included. And I think you mentioned there was the Jadel e-learning that's on the Goodfellow site, which has a lot of information around Jadel insertion. Someone's asked, where exactly is the correct placement for a Jadel, because I see them in different parts of the arm.
Yeah, so when there was the sort of spate of deep insertions, the sort of quite clear guidelines came out where the implants needed to go. So they should go about a third of the way up the upper arm. I haven't actually got like a sulcus. That's my problem. I haven't got a sulcus, so I can't show you. But a third of the upper arm, but above the sulcus, so really more over the biceps. Because if you put it in the sulcus, that's when you're at danger of, if you do a deep insertion, which we hope wouldn't happen, might end up where you don't want it. Mm-hmm. Yeah.
How hard? Oh, yeah.
Oh, sorry. I was going to say I did a talk on this a while back, and some of the midwives were concerned that if you have Jadel over the biceps and the baby's breastfeeding, it might bother the mother or the baby, and they were wondering if you could put it then more underneath the arm. The only problem with that is that the ulnar nerve runs under there, so probably not such a good idea.
There's been a couple of comments about rural medicine, which means it's hard to get enough patients, but equally that's not offering your patients enough choice to. So I guess it's just more a reflection on that access issue within New Zealand.
Yeah, absolutely. And I did talk to some rural GPs when I was doing my study, and that's exactly what happened. And that's why we were talking around the idea of there being a hub within a rural area where that's where patients would go, and then if you could go there and do sessions and keep up your skills that way, that would be one way around it. Because I completely agree, if you work in a small rural practice and you're only going to get to do a few procedures a year, then that's a barrier, isn't it, if you're set a limit for credentialing. So all of these things have to be looked at. Yeah, it's a toss up between really good training and safety for the patient, but then also hoops which make it difficult. After I left the UK, to become a trainer, to train people to do procedures, they brought in a rule that you had to have a diploma of medical education. So the hoops got higher and higher, making it more difficult. So yeah, it's a balance.
How hard is it to remove a Jadel? Is it ever easy? And I understand that sometimes that procedure can take longer than actually inserting it.
Oh, absolutely. And again, that's the other thing. A lot of people are trained to put them in, but being trained to put them out, not so much. So sometimes it can be very difficult. Women come and see me, particularly at the clinic that I now work at in Mangere, who've had Jadels in maybe since their babies were born 5 years earlier, and they really want them out, but they haven't been able to find anyone who can take them out. So that is a concern, that women have a contraceptive that they can't actually remove. So I feel that the training for removal is really, really important. And yes, it can be tricky sometimes. I have a fabulous helper on a Thursday, and Ruth might be watching, and Ruth has developed this really clever technique where she helps me. It does help if you've got someone with you. When you first see the implant beginning to poke its way out of the hole, she stabs it with an orange needle and then holds it, because sometimes you've got lots of fibrous tissue that you have to sort of tease off with your scalpel, because they can really be knitted in there after 5 years. So yeah, sometimes it can be tricky, especially if they're deep.
Well, moving on from Jadels, because we've only got a couple of more minutes, how long should we advise women to wait before an IUD removal if they bleed continuously after insertion? You touched on a bunch of that
Mirena before.
Or it's just said IUD, any form of IUD.
Well, I think it would be unusual to have bleeding after a copper IUD was fitted. So that would be unusual. So you'd want to be looking for the causes of the bleeding. So I'm thinking maybe they might be Mirena. So I never do follow-up checks for IUDs now, particularly for Mirena. I ask the patient to come back if they would like to, because what used to happen is that I would say come back at 8 weeks, and everyone has still got bleeding at 8 weeks, and so it's actually better to say you're probably going to get up to 12 weeks bleeding. I'll make it longer so that if that doesn't happen, that's a bonus. But the vast majority of women, the bleeding will have settled down by 3 or 4 months, and by a year you've got a 90% reduction in bleeding, and most women have little or no bleeding. And I have so rarely had to take out a Mirena because the woman was unhappy, whereas I every week am taking out Jadels, unfortunately.
Okay. Are there any IUDs that are, of the currently available ones, that are easier to insert? than others?
Well, we haven't got a vast choice, to be honest. There's been a lot of debate about the funded copper one, because I think the insertion tube has changed a little bit. I mean, to me, it does seem a little bit more bendy, and yeah, so I wouldn't say any of them are more easy to insert. I know people used to like the old multi-load, but that had a habit of the strings breaking, and also sometimes the little, shark's teeth would get embedded in the endometrium, and that wasn't very nice when you had one foot up on the bed trying to pull it out. So I like the copper IUD, but I agree that the insertion tube is not brilliant. But again, it all comes with lots and lots and lots of practice, and also making sure that when you push the copper IUD right up to the top, you've got a nice little round, semicircular dome poking out, so you haven't got like a horrible scratchy straw that you're trying to get through the cervix. You've got a nice little roundy top, which makes it easier.
Is using a paracervical block for nullets for Mirena insertion done much or at all in general practice?
So yeah, this is interesting. So I never ever use contraception. No, I do use contraception. No, I never ever use that other thing we just
the
talking
paracervical
about. Yeah, that thing.
Yeah.
Anesthetic. That's the word I'm looking for. Yeah. I've never ever used it. I've never found it's necessary ever, even for nullets. And the most effective thing is what my friend over here, Professor Gilbo, used to call vocal local. So basically, it's having someone with you in the room who is really calm and relaxed, and hopefully you're calm and relaxed as well. I always put on music. If everyone's calm, it's a really nice experience, and that has more of an effect than any local anaesthetic. And as someone who's had 4 IUDs myself, the worst one was the one with local anaesthetic, because it's quite sore having it put in, and you can get quite profound vasovagal. And even I've used dilators many times on nullets without anaesthetic, and if you are gentle and confident, you will be fine. I was taught using Instilla gel, the xylocaine gel, and then it's been hard to get the last few years, so I've just stopped using that as well. So now I don't use something.
Yes, I think Helen's written the same things. I use paracervical blocks, but it only helps for reducing cervical shock, and vocal local is a way better. There's a couple of questions about the type of tenaculum. Is there a type of tenaculum that is less likely to cause pain and bleeding?
Yeah, the most spiky thin one you can find. Okay, so you don't ever want to use like a crushing forceps, because your patient will never come back ever. So if you use just the thin single tooth tenaculum and put it on really slowly. I was taught this technique by a gynecologist. So just really slow, really, really, really slowly. Don't take a bite, because that's not very nice. And again, the patient won't thank you.
And it says someone's asked, do you apply the tenaculum to the anterior or posterior cervix?
Whichever's easier. So often it depends which way the uterus is pointing. Yeah. So anterior lip is definitely easier to straighten out the cervix, but sometimes really it's easier to put it on the posterior lip. Yeah.
Okay, I think we'll go for a couple more questions. We've already run over time. I know there's so many coming through, but as Orna said, we can get in touch with her with some more. The last two, one is when do most spontaneous expulsions of Mirena occur? I routinely ask my patients to see the practice nurse at 2 weeks for a thread check. Is that really necessary?
Is that from Alan?
Yes.
Hello, Alan. No, I don't think it's necessary, actually, unless the woman wants to come back. If you're worried about expulsions, so the quoted rate is about 5%, and if it is going to happen, tends to be earlier, but I don't know if that justifies a screening program of inviting everybody back at 2 weeks. Probably just get the patient to check their threads themselves if they can.
Okay. Now, there was a question here about, I'm just sorry, excuse me, I'm just going to find it. It was about Norman. Someone's been very patient waiting for this. How good is Norman in helping the skin compared to Jeanette, which I think you mentioned a little bit about before, so someone may have missed that.
Yeah, probably not as good is the answer, because the reason Jeanette works for skin is because it has, progesterone in it, which is an anti-androgen. So that's how that works, and Norman doesn't have that. So, but if someone has acne that they want treated, I would probably treat the acne with something specific for acne, and then give them something else for their contraception. That's probably the way I look at it these days.
We've just had something come in from Helen that in adolescence, expulsions happen throughout the 5 years, so the checkup at 2 weeks is not deemed necessary.
Okay, thank you. So the Helen who is helping me from afar is Helen Patterson, who's a gynecologist. Thank you.
So thank you, Orna, and thank you everyone who's been a part of the webinar tonight. I think both with comments and questions, and there's been a huge amount that has come through, so I apologise if we haven't got through everything. You are welcome to contact the Goodfellow Unit or Orna directly to ask any more, and apologies again if we haven't got to you. Hopefully we've covered a huge amount in a short time that will be helpful. So thank you so much, Orna.
Oh, pleasure, Helen. Thank you. Thanks very much for listening.
Good night, everyone.